All right, it's Paul. We're going to do a lesson about neurological drugs, and then that'll be a nice dovetail into psychiatric drugs. So here we go. Here's the agenda. You can see it on your own slide. I don't have to read it to you because, you got the slides in front of you. I also don't have to read to you about the neurons because you already know about neurons. You know that they have the dendrite thingies and they have the axon, and around the axon are all these Schwann cells. And these Schwann cells are essentially insulation. They contain the myelin sheath, and that insulates the axon from short circuiting, so to speak. The Neuro-effector Junction is where all the action happens, right? So the movement of these neurotransmitters from one place to another exerts an effect, whether it's at a neuron-to-neuron junction or a neuron to a muscle cell or what have you. All of those things happen at this little cleft between the neuroeffector, or at the neuroeffector junction, this cleft between the presynaptic cell and the postsynaptic cell. Now remember, there are specialized areas of the brain. There's the prefrontal area. Broca's and Wernicke's areas are the language centers. They're in the left hemisphere. We have the motor strip here at the central sulcus, and the sensory strip as well. So the motor strip, sensory strip here, and the visual cortex then in the back so that you can process those visual signals, and then the cerebellum, which coordinates things, not just movement, but also thinking. Now, you may remember the homunculus dude, and this homunculus guy shows you the parts of the brain that are responsible for motor and sensory input. So the motor output goes from the inside of the sulcus to control the toes, the ankle, the knee, the leg, the hips, and all that. And that's a lot of your body there in a very little space. And the reason is that there's not a whole lot of neurons that connect with the brain there. But look at how much space the thumb takes up. I mean, that's a huge amount of space, right? Because that's a very complex thing that the body has. Fingers and hand, etc. Also then the face, the tongue, the jaw, swallowing requires a lot of brain power as well. Then the sensory part, genitalia, very small part, feet, hips, trunk, head, neck. Again, the hand is very highly sensorized. I don't know what to say, but a lot of nerve fibers there. And then the face as well. And so you know how tender it is when you bite your lip, for instance. Well, there's the reason, because there's a lot of nerve fibers that go from your lip to your brain. There are motor and sensory pathways that control the flow of information to and from the brain, and they are pictured here. So here we have the neuromuscular junction. So these are the motor tracts, and these are referred to as descending tracts, right? Because they come from the brain down through the thalamus, they go into the spine, they cross over the cord, and then they go down to the neuromuscular junction. And those are important when we talk about some of the side effects of medicines that we're going to discuss later on. The ascending pathways are the sensory pathways, and these are things like the reflex arc, for instance, that does, by the way, involve the brain. Part of the reflex arc is the brain. Come back next year for 405B with me, and I'll teach you all about that too. So the major spinal tracts, again, are either motor or sensory. They don't carry both, right? You need a particular major highway to get from one place to another. You want to get to UP, you got to go 322, right? You want to get to Philly, you got to go on the turnpike. And those specific ways to go are analogous to the tracts in the cord. All right, so let's first talk about stimulants. You may have used this yourself or have friends who or siblings who do. You know that ADHD affects 3 to 10% of all school-age children. It's also used, though, for narcolepsy. So this is an incurable neurologic condition that just makes people fall asleep for no good reason. It's also useful in obesity as an appetite suppressant. Can be used in migraines, and they use it in neonatal apnea as well. So what are the drugs for ADHD and narcolepsy? Well, the standard Adderall and Ritalin and Strattera and those medicines that you know of. I'm sorry, let me back up. The standard stimulants, Adderall, Ritalin, Concerta, those that you know about are shown here. There are some newer ones like Strattera. The beautiful thing about that is that it's non-addictive, right? And so people who are concerned about the addictive component or the addictive nature of stimulants may find it easier to take Strattera and still get the relief from their symptoms that they need. There are some downsides to it, may cause suicidal thinking and may cause people to act on it as well. And then there's Vyvanse, that is a prodrug for dextroamphetamine. Remember what a prodrug is? Think back to week 1 and remember that a prodrug is a substance that goes into your body, is kind of inert as that substance, but then your body processes it, turns it into a drug, and then that is the active thing. The active metabolite is what does the trick. Okay? So Adderall is one of the drugs for you to learn. It stimulates areas of the brain associated with mental alertness, and it increases the effects of norepinephrine and dopamine. There are contraindications and warnings, structural heart abnormalities, also known dysrhythmias can be an issue, hypertension, and then some other things like Tourette's and other disorders that have tic associated with them. Not the bug tick, but a tic meaning an uncontrollable motor response that the patient has, like twitching or something like that. We're going to talk about MAO inhibitors, but just now memorize that you can't use Adderall or any stimulants within 14 days of using an MAO inhibitor. We're going to talk about that why later, but just memorize it for now, okay? Adverse effects with Adderall include increased heart rate and blood pressure, rarely, anxiety, insomnia. That is a major issue, actually, insomnia, if you take it too late during the day. So they have long-acting forms of these drugs, and they have short-acting forms of these drugs. And the long-acting forms, you have to make sure that you don't take too late. Well, you can't take the short-acting form too late either, but the short-acting form only lasts for a couple of hours, so... So those are the adverse effects to know about, and then know that interactions can happen with other CNS stimulants, which can just increase their toxic effects. All right. Migraine headaches is another indication for medications. So I just want to clear the air about what a migraine is. So I've heard students and younger people all the time refer to, and older people, it's not just younger people, but I've heard people refer to the fact that they have a migraine. And what they are experiencing is a headache. That is the word for it, all right? It's a bad headache, so they say, oh, it's a migraine. Well, that's probably not accurate. So a migraine is a specific, recurrent, disabling headache that is pulsatile oftentimes, and the most important thing is that it's disabling, all right? These are specific types of headaches. There are other types of headaches. What you and I typically have are tension headaches. So just be careful with this term. Migraine is a specific kind of headache that is a vascular cause, all right? And that vascular cause makes it amenable to treatment with certain medicines, like, for instance, Imitrex. Imitrex, or sumatriptan, is a medicine that acts on the vasculature in the brain. And the good news about this is that it can bring relief to patients who have migraines. It can be used at the very beginning of a migraine to ward off the evil effects of the migraine. The onset of action is about 30 to 60 minutes, and it lasts about 4 hours. They are terrific medicines and have changed many lives. The downside is that there is some cardiovascular, cerebral vascular disease risk. So these medicines have been associated with strokes in certain people, particularly in women. So they're not cuddly drugs necessarily, right? Cuddly drugs means that they're drugs that we give and we don't have any concerns about giving them. There's not a lot of drugs that fit that mold. And certainly Imitrex is not one of those cuddly drugs. All right. It is contraindicated in uncontrolled hypertension, arterial disease, dysrhythmias, and also in glaucoma, which is the increased pressure in the eyes. So I'll let you keep reading about that. I have a little, what do you call this? I forget what you call it, but it's an image here that should help you to remember what the medicine does, how it acts. It's a little mnemonic. That's it. It's a mnemonic device. All right. You watched the film on Parkinson's on the weekly webpage, so here's a link to another film that may give you some additional information. I'm not going to go through and review what Parkinson's is because I don't want to waste your time. Remember, though, well, I guess I am going to review it, right? So it's an imbalance of acetylcholine and dopamine. And the classic Parkinsonian symptoms you should just memorize because they're going to come in handy later on when we talk about something else. Akinesia is one of the symptoms that happen in classic Parkinson's disease and other Parkinsonian symptoms or conditions. Akinesia is the absence of motor activity, and that results in a mask-like facial expression. So patients with Parkinson's disease or Parkinsonism often don't have the ability to smile or frown or do anything like that. It's as if they're wearing a mask. There's also bradykinesia, which is slowness of movement, so they walk very slowly. There's rigidity, particularly this cogwheel rigidity that I think they demonstrate in the video link that I have there for you. And then this pill rolling tremor that people get where they have a tremor of the thumb against the forefinger, and that's typically at rest, and when they're active, that tends to go away. And then there's also postural instability, which just means that they're at risk for falls. This is the typical kind of patient. Notice the mask-like face, no expression on his face, stooped posture, very rigid, and short shuffling steps. And don't forget the tremor too. Okay. Anti-Parkinson agents then are aimed at the tremors and all the other symptoms associated with it. So here's another mnemonic device for you to remember the components of anti-Parkinson's medicines. So the major classes are Levodopa, Carbidopa, also known as Sinemet, that's the trade name. And then we have dopamine agonists and anticholinergics and COMT inhibitors. And then we have combination products that mix all the best features together. So the one that you're going to memorize this week and know inside and out, because you're going to give this no matter what you do for the rest of your nursing career, because there are plenty of patients out there who have Parkinson's disease or Parkinsonism. So learn Levodopa, Carbidopa, and again, the trade name is Sinemet that you'll mostly here. So the mechanism of action is that it promotes the synthesis. It makes the brain make more dopamine. All right. And then carbidopa is something that prevents peripheral breakdown of the levodopa. All right. Adverse effects are nausea and vomiting, dyskinesis, or dyskinesias is what this says, orthostatic hypotension, which means that when you stand up too quickly, your blood pressure goes low when you pass out. And then psychosis can also be a problem. Nursing implications are dosage timing. So let's talk about that. This medicine only works when it is in the patient's body. All right. It has a pretty short half-life, doesn't last for very long. The therapeutic half-life doesn't last long. And so we need to make sure that when this patient is in the hospital, that they get their medicine at the beginning, when they're getting up and about. So imagine being tied down or restrained from 6 a.m. when you wake up until 9 a.m. when we decide that we're going to give the morning meds, right? So how would that be if you had Parkinson's disease and you were stuck without your medicine for the first 3 hours of the day, and then the nurse is yelling at you because you weren't eating breakfast and you didn't get up and go to the bathroom and yada, yada, yada. Well, that's because you have me tied down, essentially. That's why I can't get up and do these things, because you didn't give me my medicine. So remember that when we have somebody in the hospital, it's important that we take a history from them and find out, what time do you usually take your medicine? What time do you wake up in the morning? What time do you get started with your Sinemet? And they'll tell you the time. They're not going to say, oh, whenever. They're going to say, I take it at 7. That's when I need it. And we need to make sure that we do that. Freezing is a problem that can happen with Sinemet, where patients just aren't able to move through their movement disorder, and freezing can be an issue. Now, interestingly, there's a fascinating trick for this. If patients are walking and they can't move because they are frozen, you can put a line down for them to step over, and they immediately are able to walk right over it. It is a fascinating thing to see. I don't know why it happens, but it's definitely a thing. And then we need to make sure that the patient does not get their Sinemet with a significant protein load, because protein decreases the availability of the drug. The next drug for Parkinson's is dopamine agonists. So these medicines like Mirapex or Requip have a direct action on the dopaminergic receptors, and that increases the availability of dopamine, right? Remember, it's an acetylcholine dopamine imbalance in the brain, and this medicine helps to jack up the dopamine side. Can cause nausea, dizziness, sedation, psychosis, and compulsive behaviors. This one you do give with food, and we often need to titrate the dose. Cogentin is a medicine that decreases CNS acetylcholine levels. So it's an anticholinergic, and we have to be careful in the elderly in particular. And guess who has Parkinson's disease often? Elderly patients. So why do we need to be careful with anticholinergics? Well, because they can have side effects that are worrisome and bothersome, particularly in elderly patients. So the fancy picture that I have here tells you that they get heat intolerance, they get dried out, they get visual problems that cause blind as a bat and red as a beet and mad as a hatter. Mad as a hatter. But those are all pretty not entertaining, right? They're pretty pictures and boring. But I got something you're going to remember forever. On the left-hand side, you see here, the anticholinergic effects are you can't pee, you can't see, you can't spit, and you can't poop. All right? Those 4 things are the ones I want you to remember. All right? You can't pee because it causes urinary retention. Can't see because it causes dry eyes and other visual disturbances. Can't spit because everything's dried out. Anticholinergics make you super dry. Have you taken a antihistamine? They're also, they also have a significant component of anticholinergic. And so if you take that, it dries you up. That's one of the reasons you feel better. And then you can't poop because your bowels don't work as well. The other things that are included, though, that you should remember are that because you're dry, it makes you orthostatic. All right. And it can make you a little congested nasally. All right. Can't pee, can't see, can't spit, can't poop. COMT inhibitors are medicines that prevent the breakdown of Sinemet. All right, so COMT prevents the breakdown of Sinemet. When they combine this medicine with Sinemet, they market it as Stalevo. They're good medicines to use together because they complement one another. All right, so that's all I want to talk to you about with that one. Make sure that you know Levodopa, Carbidopa, and that is Sinemet. So let's talk about Alzheimer's disease. Remember, the pathophysiology is that it is a neurodegenerative disorder that never gets better. All right. It's characterized by neurofibrillary tangles and plaques. Those are the things that we see. There's these amyloid plaques that we see on autopsy, and then there's these tangles that happen as well, and these tangles are made up of this tau protein. We don't know if these come first or are the result of the disease. So there's ongoing research to try to figure that out. And one of the research projects was featured in a 60-minute story that I gave you a link to as well. Take a few minutes and watch it. It's fascinating. The other thing that characterizes Alzheimer's disease is decreased levels of acetylcholine. And you probably know that there's a dramatic risk increase with aging and a family history. So the symptoms are progressive memory loss, global cognitive deficits, executive planning, which is your ability to, manage yourself, essentially, impaired speech, and later in the disease, it's an inability to take care of yourself entirely, and eventual death. So there's a lot of research going on trying to find an adequate treatment for Alzheimer's disease. And the first set of drugs that came out were cholinesterase inhibitors to reduce the breakdown of acetylcholine. And these drugs work inside the brain in an effort to keep acetylcholine running around and maximize the bioavailability of it. So the first one and the prototype that we're going to talk about is Aricept or donazepam. Donapazil. Actually, I don't think I've ever said that generic name, Donepezil. I don't think I've ever said that. I've always ever said Aricept. Anyway, again, these prevent the breakdown of acetylcholine. The benefit to these is that they have mild symptomatic improvement, or they delay the progression of the disease. It only works while the patient takes it. If they take it and it stabilizes their disease for a period of time, that disease accelerates again as if they didn't even use it at all if they stop using it. Does that make sense? So they take it for, let's say they take it for a year, and the disease has been slowed down because the acetylcholine is still around. They've had a slower progression, but then if they stop the medicine, they decelerate quickly as if they never even had the medicine, and they go right back to lower than baseline. They go back to where they would have been had they never had the medicine to begin with. It's kind of a cruel thing that can happen if you stop the medicine. So we definitely don't want to stop this medicine. All right. An important nursing implication for this drug is making sure that the patient and the family have realistic expectations. It's not going to cure the disease. It doesn't do that by any means. It simply slows the rate of progression. All right, multiple sclerosis is a horrific disease that affects many people. It is characterized by demyelinization of the CNS, and it's an autoimmune cause. There's lots of different presentations. The most common presentation for multiple sclerosis is numbness in the feet. So numbness of the feet is a typical presenting symptom to neurologists, and when they find that, they usually do the routine testing. The first test is a B12 level, because B12 can be associated with certain neuropathies like numbness in the feet. And once in a while, you pull that trick out of the hat, you find somebody who has numbness somewhere. It's kind of weird, vague numbness symptoms. You check a B12 level, and you make them feel very good that they don't have multiple sclerosis. You give them B12 shots and they're good to go. All right. I'll let you on your own learn more about multiple sclerosis. That's not the point of the course. What I want to talk to you about is the fact that we have 3 subclasses of drugs that we use for these patients. They are interferon beta 1A, Avonox, interferon beta 1B, and the one that you probably have heard mostly about, if you've heard of any of these at all, is Copaxone. All right. So Copaxone increases the production of the anti-inflammatory suppressor T cells. That's how it works, because they have been associated with improvement in symptoms and slower progression of the disease. It's an injectable, and there are often, or I should say the most common adverse effect is injection site reactions. We monitor the patients for those as the nurses taking care of the patients. And we also have to know that because we're messing around with the patient's immune system, we have to keep in mind that we may mask the patient's normal tumor surveillance mechanisms and their normal infection fighting capabilities too. Because this is a autoimmune disease, when patients have MS exacerbations, corticosteroids are very useful. All right. And corticosteroids like Solumedrol or Solucortef or, hydrocortisone or whatever, IV corticosteroids have terrific effects in reducing inflammation. That is one of their major effects. There's a lot of side effects with these drugs, though, and they cause hyperglycemia. You may know that already from clinical. They can cause peptic ulcer disease, and they definitely make you hungry. They can cause psychosis. They can cause sodium and fluid retention, immune suppression, which is one of the reasons that we use them for this disease, right? Because we're trying to suppress the immune system. It can cause fat redistribution, and people get that thing that's referred to as a buffalo hump on their upper back. And then there's loss of bone and muscle mass. There's all sorts of things. So corticosteroids are very cuddly drugs at first, and they are not cuddly drugs later on. These side effects can become disabling, but initially they make you feel really, they definitely make you feel better. So, I used to have a joke that I told during class. It's a whole lot better when I'm in front of you, but if I'm going to be on a deserted island and I need one medicine to go with me, it's going to be steroids. All right. And beta blockers, and aspirin, because those are, and probably Motrin, because I like Motrin. Although if I have the corticosteroids, that probably negates the need for the Motrin. All right, corticosteroids, beta blockers, aspirin. Those are the things that I want with me because they will save my life and make me feel better. All right, and chocolate, probably need that too, and ice cream, but whatever. It's important that you know, every single nurse should know, that steroids have to be tapered over a period of days. And why is that? So here's the simple explanation. Since we're giving that dose, it's exceeding the amount that's produced by the adrenal glands, and that makes the adrenal glands stop working, right? Because of that negative feedback loop. We'll talk about this later, but in a later class. That negative feedback mechanism tells the adrenal glands that there's plenty of corticosteroid floating around in the body, so just stop. Don't do anything. So if the patient's on corticosteroids for an extended period of time, and then they suddenly stop them, then they can have adrenal crisis, right? And that's a bad thing. So steroids have to be tapered over a few days so that we don't put people into adrenal crisis when the steroids are stopped. Okay? You're going to hear that multiple times, but learn it now. Okay? Next, we're going to talk about anti-epileptics. I'm very happy to tell you that this is a good time to be a nurse because it used to be that we only had one choice for anti-epileptics, and that choice was horrible. When I first started, it was a terrible choice. The only drug that we had was Dilantin, and it sucked. All right. Now we have a whole lot of better ones. So we use these drugs for seizures. We also use them as mood stabilizers in bipolar disease. We can use them for migraine headaches and neuropathic pain as well. But we're going to talk about how they're used in seizures. So remember I told you Dilantin is a horrible drug? Here it is. You're going to learn about it because this is an important drug for nurses to know about. It's also illustrative or illustrative of bad effects from drugs and how we can protect our patient and how we have to do that. All right. This is a drug that has a narrow therapeutic index. Remember, a little bit doesn't do anything. The right amount does the trick. And then just a little bit more makes you sick. All right. So what are the problems that can happen with it? Well, one of them is CNS suppression. So it can make you sleepy. All right. The other thing it can do is over a long period of time, it can give you a gingival hyperplasia where the gums in your mouth get super swollen. And you know what? If you need this medicine for fun, then it wouldn't be a big deal and we could just get rid of it and your gingival hyperplasia would go away. But that's not the kind of drug this is. This is a drug that's needed to survive. And when patients had gingival hyperplasia and we didn't have anything else, it was a real problem. The other thing that you can get is a skin rash that's really severe called Stevens-Johnson syndrome. And it is a mess. So here's gingival hyperplasia. This is a little example of it. You can see how thickened the gum line is. This tends to happen in blacks more than whites, and it's mostly cosmetic, but can also cause bleeding in the mouth. So the IV form of Dilantin is phenytoin, which is compatible with almost nothing else. And if you give it too fast, the blood pressure goes to nothing. And if it comes out of the skin or out of the vein and goes into the skin, it's a vesicant and causes all the tissue to die there. So thankfully, there was a drug invented called fosphenytoin, which is similar to phenytoin, but it's a prodrug, right? So it doesn't have any effects in the body until it's converted to Dilantin by the body. So we have less cardiovascular risk, less caustic if it infiltrates, and this was a pretty good interim step to the more modern drugs. This is a picture of what happens with Dilantin infiltration, and this is this is just the kind of thing that can happen with vesicants getting into the skin. So today we have these fantastic new other anti-epileptics like Tegretol and Depakine. Now they still require monitoring. They still have sort of narrow therapeutic indexes or indices. So we have to get drug levels on those things. And they also have potentially dangerous side effects, but there are other choices, at least, other than Dilantin, and that's useful. The biggest thing to hit the epilepsy world was Keppra. So Keppra is really becoming the drug of choice, if it hasn't already, for controlling seizures. It has my favorite mechanism of action, exact mechanism of action unknown. I love that. Like, how can we not know how a drug works? Well, we don't. So the exact mechanism of action is unknown. We just know that it works. All right. One of the downsides is that it can be sedating, but there's no significant drug-drug interactions, and we don't need to monitor levels. We can just give enough of it until they stop seizing. It's really a magnificent drug. I mean, it really is. Neurontin is a drug that you probably have heard about. Maybe you've given it in clinical. Maybe your grandparents are on it. It's a medicine that we use mostly for neuropathic pain. I kind of think of it, this is unfair, but I kind of think of it as a nerve vitamin, right? And what I mean by that is that it has sort of a modest effect. But it's very safe, and we can give it in high levels, and it's very well tolerated by most patients. And the most common adverse effect is CNS depression. So, it's a pretty convenient drug to use, and we can use it at higher levels without any substantial problem. So, you'll probably see this drug a lot. Now, just as a little aside here, when we have a patient who is in status epilepticus, which is just continuous seizures for an extended period of time, that can result in brain damage, acidosis, hypoglycemia, death, etc. And so we need to treat them and try to make these seizures stop. One of the things that we use is Ativan, all right, or lorazepam, or some other benzodiazepine. We talked about benzos. So you should know some of the effects of benzos. One of them is a muscle relaxant effect. So add this to your list of things that we use it for. Status epilepticus, seizure disorders. And then we also give fosphenytoin or Keppra or some other anti-seizure medicine for these patients with status epilepticus. Now, years ago, I'm going to tell you a little story here, and you're going to be shocked about this. There was I'll tell you the whole story. That children with intractable seizures have had two different treatments that have been shown effective. One is a strict ketogenic diet where they eat bacon and butter at every meal. Maybe not those foods in particular, but that's the kind of diet that generates ketosis. Maybe some of you have heard about ketosis and the ketogenic diet. Maybe you know more about it than I do, but it's essentially mostly a fat diet with a modest amount of protein in it and almost no carbohydrates. So that's one thing, but you can imagine how a kid at a birthday party would do if they were on a ketogenic diet. Then there was surgery that was first done, I think in the 50s or so. And what they do is a hemispherectomy, where they take out the side of the brain that is broken, right? Where the seizures are originating from. And usually it's not a well-formed hemisphere anyway, and it's characterized by just chaotic neurons that aren't in any particular order, and it's that hemisphere of the brain's never going to work anyway. Fascinatingly, if you take that hemisphere out before age 6 or so, your other hemisphere will learn to compensate and will be able to do all those things that the other hemisphere was supposed to do, but can't because of this intractable seizure. And there was a particular surgeon at Hopkins in the 1980s who revitalized the hemispherectomy. You know who this guy is? He's Ben Carson, who happens to today be the director of housing and urban development in the Trump administration. So think of him what you might as a Trump administration person and as a former presidential candidate himself, but he was some kind of brain surgeon, just an incredible neurosurgeon. So now if you need a break, you can take a little break. We're going to change gears and talk about some psychiatric drugs now. First, you should know about psychosis. So psychosis is what you may think I have. No, I'm just kidding. It's characterized by impaired perception of reality. Can be hallucinations or delusions or paranoia or several of those. Its causes include schizophrenia. It can be caused in bipolar disorder. It can be seen in severe depression. It can be seen in substance abuse. It can be seen in other neurological diseases. Psychosis is a big problem because, you lose your sense of reality. So remember that hallucinations are sensory impressions without any external stimulus. So people see things like bats, I guess is what that is in this case, or they see some other thing that doesn't really exist. Or they can have illusions, which are real stimuli that are misinterpreted. So somebody in this picture is waving at the guy, and what he sees in his mind, or the way he interprets that wave, is that the guy is threatening him with a knife. All right, so that's an illusion. And then there's delusions that are false fixed beliefs. So this woman thinks that she is Cleopatra, for instance, or, somebody thinks that they're Jesus Christ, or, any number of other delusions that have been popularized in movies and such. Schizophrenia is just a terribly horrifying disease. This is a disease that strikes people in their early 20s, just about the same age you guys are, and is essentially a severe, persistent mental illness that never gets better. And so people grow up and they have normal development, and they, come from a healthy background and family and everything. And then one day, in their late teens or early 20s, often during college, they have their first psychotic break and are then diagnosed with schizophrenia or schizoaffective disorder if other things are involved. So essentially, this is a dopamine imbalance. And we have positive and negative symptoms. Essentially, you can think of positive symptoms as not good symptoms, but rather these are positive symptoms that we can see in the patient and that the patient experiences. You can think of this as like a sign, for instance, something that we can observe from outside. Agitation, psychosis, we can see it. Negative means that they're internalized to the patient. So they have social withdrawal. They don't have any motivation to do anything. They lose functional capacity. Those are negative kind of symptoms. All right. So we have a long history with psychosis in this country, and you probably know about a lot of those things. And you've seen the movies that have characterized them as well. But the real change in the way that mental health was handled in this country came in, and worldwide, came with the advent of the antipsychotic medicines, the neuroleptics. So this really began to change in the 1950s. Haldol was an early antipsychotic. I shouldn't say early. It's one of the more modern antipsychotics that actually were beneficial and had an effect. They are dopamine receptor blockers, and they do have some adverse effects associated with them, like extrapyramidal symptoms. We'll talk about that in more detail shortly. All right. Neuroleptic malignant syndrome, or NMS, is another potential adverse effect. Sedation can be a major problem with Haldol. In fact, sometimes it's used for its sedative effects. Orthostatic hypotension, again, any of these drugs that affect your nervous system and that hit dopamine in particular tend to have orthostasis as one of the side effects of it. And then there's anticholinergic side effects that are associated with these drugs too. So let's talk about extrapyramidal symptoms, because this is really important with this drug class. All right. And if you learn nothing else in pharmacology, I want you to understand, well, that's probably an exaggeration. There's lots I want you to know, but this is the most important thing to know when you're giving antipsychotic drugs. Can we just say that? All right. So extrapyramidal symptoms include pseudoparkinsonism. Remember I said keep an eye out for the Parkinson's symptoms again, because you're going to need them later. Well, it's later. All right. So people who are getting extrapyramidal symptoms, this is a side effect of some of these antipsychotic drugs. But pseudoparkinsonism is that the patients develop the stooped posture, shuffling gait, rigidity, bradykinesia, that means slow movement, tremors at rest, pill rolling motion of the hands. Those are extrapyramidal symptoms. They are from the extrapyramidal tract, the motor tract in the spinal cord, and we're poisoning that extrapyramidal tract and making these symptoms appear. Acute dystonia is another one. This is an abnormal facial grimacing with an involuntary upward eye movement. Remember that. That is kind of the important part to remember. Muscle spasms of the tongue, face, neck, back, etc., and laryngeal spasms, which can cause breathing problems. So acute dystonia, this happens, in an instant. All right. Pseudoparkinsonism often develops over a longer time. Akathisia, restlessness, trouble standing still, pacing the floor, constantly moving, rocking back and forth. Those kind of symptoms are akathisia. And then tardive dyskinesia, which you may have heard about before. This is sort of the worst of all of these. The other ones here are reversible. Tardive dyskinesia, after it's happened for a long period of time, can be irreversible. And I once had a patient, this was, probably a year ago or so, I saw somebody in the office who had tardive dyskinesia symptoms, and I recognized them. And so I said to her, so what is the lip smacking? And I think I found a nice way to ask this question, because it sounds terrible, right? But tell me about the symptoms that you have there, with your dyskinesia. And she said it's tardive dyskinesia, and my psychiatrist said that there's nothing that can be done about it. So, she knew that she had it. She developed it at some point. It's unfixable now, and, she lives with it. So these are important, critically important things for you to be able to recognize as the nurse giving these medicines. So don't think for a minute that you're just the nurse, you're just going to show up and you're just going to give the drugs and go home and pay for your refrigerator that you're buying, right? These are important things that we're doing as nurses. It's your job to recognize these side effects, all right? You're not going to get away with somebody else being able to do it. It's your job. So make sure you understand it. And if you don't understand it, don't do the job. How's that? Firm enough? Okay, good. So the next big side effect that can happen with these drugs is neuroleptic malignant syndrome, or NMS. This is a very rare thing. I've never seen it before, but it is a life-threatening reaction to many neurologic drugs, particularly the antipsychotics. It causes severe muscle rigidity, which causes a high fever, can later progress to organ failure, and it is a medical emergency. The first thing you have to do is stop the drug immediately. We administer muscle relaxants then. And remember, when we give muscle relaxants, what do? You got to paralyze, or you got to sedate the patient, right? If you're going to give a paralytic, you got to sedate the patient, because the paralytic doesn't sedate the patient. We give antipyretics to lower the temperature, so Tylenol essentially, and then cooling blankets, and we get them through this phase. It's a bad thing. Thankfully, it's very uncommon, but characterized by a really high fever, and you need to recognize this right away as well. Okay? As if those things aren't bad enough, there's other little annoying things that happen with antipsychotics. Although they are good for positive and negative psychotic symptoms, and the newer atypical antipsychotics have less EPS and tardive dyskinesia, they do have some other annoying effects, such as weight gain. So some of these newer antipsychotics still have tons of weight gain associated with them. And we're going to talk about Risperdal as the prototype for the drug class. It is a major problem in kids who are taking this. And I happen to know this because my wife's a psychiatric nurse practitioner who works in the autism program at Hershey. And, she has patients that, are young kids who have autism or other behavioral problems, and she has to use antipsychotics. And as soon as she puts these kids on it, she knows that there's a better than average chance that they're going to end up gaining a lot of weight. And, it's the one thing that makes the kids able to engage in life, but at the same time, it makes them obese, maybe gives them diabetes, dyslipidemia. In younger kids, obviously, this isn't important, but in teenagers, sexual side effects are a major issue. They still have the risk of extrapyramidal symptoms. And then there's some other heart-related problems, like the potential for myocarditis or prolonged QT interval. So here's a comparison of some of the antipsychotics that are out there. So the typical neuroleptics are either slightly or substantially likely to cause extrapyramidal symptoms. Tardive dyskinesia in particular happens with the typical neuroleptic drugs like Haldol, for instance. Okay, but Risperdal may decrease your chance of tardive dyskinesia, right? So it's 1+, or maybe not even that much, to 2+. And then the other ones that are listed here, we're not as sure about, but they really don't have much in the way of tardive dyskinesia potential. Somnolence, Risperdal is much less sedating than the other ones. It may be associated with higher prolactin levels, so you have to check prolactin levels. That's one of the prolactin is one of the pituitary hormones, if you have forgotten. Just thought I'd remind you of that. Risperdal is supposed to be the least contributing to weight gain, but it's a substantial problem still. So just so you can see, there is some relative improvement in the Risperdal profile compared to the typical neuroleptic drugs out there. All right, let's talk about antidepressants. So depression is a very, very common, in fact, the most common mood disorder out there. It differs from, people being sad, right? Depression is a diagnosis. I know we all talk about, oh, I'm depressed today. Well, that's not major depression. Depression is where you're depressed for an extended period of time. And you may be severely depressed for an extended period of time to the point where you become psychotic, you disengage from life, you either sleep all the time or you can't sleep at all, and everything in between. All right. So the symptoms associated with true depression are severe, and suicide is a major risk in these depressed patients. So we really wanted to come up with some methods, some drugs that would help these patients, because we know that psychotherapy and exercise by themselves don't work, but they are an important component of a holistic plan of care. So let's just look at this for a second. At the low end of this, on the left-hand side, are drugs that affect a few neurotransmitters. At this end, we affect all the neurotransmitters. At this end, the medicines have less severe side effects, but they're less effective. And as we get up here, they have more severe side effects, but they're way more effective. So we talk about SSRIs like Prozac, for instance. SSRIs are just a little bit better than placebo for depression. By the way, for anxiety, they're fantastic. They are fantastic for anxiety. But for depression, SSRIs are just a little bit better than placebo. If we need something stronger than that, then we go to the next class, the SNRIs. They're a little messier. They mess with more neurotransmitters, and they have more side effects associated with them, but they work better. And then if that's not effective, then we go to the tricyclics. And the tricyclics have even better efficacy. They work better, but they're a little sloppier, right? And with these medicines, if you overdose on them, you are at risk for sudden cardiac death. So that's not a cuddly drug, right? But they work. They really do. They work very well. They work way better than SSRIs. They work substantially better than SNRIs. They're not as good as MAO inhibitors. MAO inhibitors are really effective. All right. They're way more effective than SSRIs, but they're a lot messier too, because if you eat a piece of cheese or a pickle, you die. Well, that's kind of a bad side effect. Not at all cuddly, right? This is not a cuddly drug. But MAO inhibitors work. Now, there are limits to pharmacotherapy, but there is something else out there that works almost all the time. And it is super messy. It messes with all the neurotransmitters, every single one. Any idea what it is? It's effective. It works. But when you get this, you may forget a period of time in your life, in the last couple of weeks. But it works. And that thing is ECT, electroconvulsive therapy. Electricity through the brain messes with all the neurotransmitters, screws them all up, makes them all no good, and sort of resets the brain. And it works. It's an amazing treatment. And the results are phenomenal, but the side effects, people don't like the idea of ECT, even though we do it in a much more controlled way now than we did in the 50s, where we didn't use anesthesia or anything. Now patients come, they lay down, we give them a neuromuscular blocking drug along with along with their sedative. We put them to sleep, and then we deliver the electricity. And when I say we, I don't have anything to do with this, but you get it. They go to sleep, they're intubated, they are paralyzed so that when the electricity goes, they don't have any muscular contraction, and they get the energy delivered to their brain. Then they go to the recovery room and they recover for a period of time. And slowly then, over the next couple of days and weeks, the brain has reset, and their depression is often miraculously gone. or at least more manageable. And it's just a fascinating thing to me to think about. So let's talk about some of these medicines. Now, the pharmacokinetics that we talked about, remember we said that typically when you get a drug into your system, you get a blood level of it and then it's effective and you're good to go. So we talk about the plasma half-life, for instance, or the elimination half-life, which is how long it's in the body. And we usually see that elimination half-life equivalent to the therapeutic half-life, right? Well, that's not true with this particular drug. So with this drug, they get the drug, and actually this was a study that was done, but what happens is that the drug gets into your body, and it takes about 2 weeks before this drug begins to work. All right. So the therapeutic effect doesn't always correlate with the physiologic onset of every drug. And this is a prime example. When you give an SSRI or most of these antidepressants, the maximal effect that you see takes a couple of weeks to happen. All right. And so just know that when you get a drug, it doesn't the therapeutic effect doesn't always correlate to the plasma or elimination half-life. Okay. So here's SSRIs. They treat depression, kinda, but great for anxiety, really good for anxiety. The response takes 2 to 4 weeks, during which time that anxiety may worsen. So they probably need a little benzo to get them through that period of time. A nice long-acting benzo would be a good thing, right? Instead of the short-acting ones. But the long-acting ones will get them through for the 2-week period. Take 1 a day or 2 a day and get you through that increase in the anxiety level. Adverse effects are very common with SSRIs, and some of them are not fun, right? So headache is a problem. Headache is also a major problem with the next class of SNRIs. My wife refers to one of the SNRIs as side effexor. The medicine's called Effexor, but she calls it side effexor because everybody she puts it on gets a headache. So headache is a big problem with SSRIs as well. Insomnia can make people very, very sleepy, or it can make them not sleep at all. It can make them insomnic. GI distress, I don't see that one as much. Sexual dysfunction is huge. A lot of people have sexual dysfunction. Men can have prolonged ejaculation with it. Women can have anorgasmia with it. These are, and sometimes, occasionally we use those drugs, not we, but occasionally these drugs are used because of those side effects, particularly in men, but they are sexual side effects that can become problematic for people who are taking them. Suicidal ideation is an issue and is actually a black box warning in teenagers and young adults. Weight gain is a major issue with this too. People tend to gain weight on these drugs. So between messing up your sleep architecture and making you gain weight and the sexual dysfunction, that is enough to make people not really want to take an SSRI. But again, at the lower doses that we use for anxiety, it's generally pretty well tolerated. Okay. So the drugs for you to know about are Prozac, Zoloft, Celexa, Lexapro. We're going to stick with Prozac because that's the one that I want you to know. It's one of the first ones. It works well. So know Prozac and understand it. By the way, just for fun, this is one of my favorite things. So you remember in chemistry class, hopefully you had chemistry class, where you talked about enantiomers, right? The mirror image drugs. So there was a drug on the market called, I forget which one came first, actually. I forget if it was Celexa or Lexapro. Anyway, let's say that was Celexa that was on the market first. And then this company called Forest Pharmaceuticals, instead of looking at all these drugs and finding their own chemical, They went and found drugs that were already approved, that already worked, and then they went to the lab and they tried to get the mirror image and reproduce the mirror image of it. And that's what they did. They took this Celexa molecule, they found the mirror image of it, were able to make it. They called it Lexapro. They tested it on patients, and they found that it's actually a little bit better than the original drug was. So they essentially stole this compound from the makers of Celexa and made Lexapro. Fascinating, right? What a great business model. Just go out there, find people who have, found a molecule that works great, and then just go to the lab and copy it, but get the mirror image of it, which is not patented, and then we'll sell it. It's amazing. Anyway. SSRIs also have withdrawal issues, so you can develop flu-like symptoms that happen when you withdraw from an SSRI. Now, they have a long half-life, right? They stick around for a long time in your body, so particularly Prozac. In fact, Prozac has such a long half-life that we can actually give it once a week, and it sticks around for that long. So if we have somebody on Prozac, for instance, and we stop it cold turkey, they are at risk for flu-like symptoms. So the way around that is to just wean the dose, right? So if they're on 40 milligrams of Prozac, for an extended period, then we would cut them back to maybe 30 milligrams or 20 milligrams for a couple of weeks, and then cut them down to 10 milligrams for a couple of weeks, and then get them off slowly. Serotonin syndrome is another syndrome that can happen where they get involuntary muscle contractions, agitation, confusion, all these things. And that often happens in overdoses of this drug. So that's something to keep an eye out for as well. All right. Serotonin syndrome is pictured on the right-hand side here. Mental changes, autonomic instability like increased heart rate, decreased blood pressure, blah, blah. Neuromuscular incoordination, hyperreflexia, those kind of things that you as the nurse can examine and find. And then symptoms of GI distress, nausea, vomiting, diarrhea. SNRIs then are the next step, right? So we have the SSRIs, which are the ones a little bit better than placebo, but really good for anxiety. And then the next step is the SNRIs, all right? And effexor, or side effexor, as my wife calls it, is the next step. Common side effect, headache, as I said, hypertension, insomnia. Sexual side effects are also common with this one. There is a black box warning, that's BBW, for suicide in children, adolescents, and young adults. Tricyclics block the reuptake of norepinephrine and serotonin. Again, the response takes 2 to 4 weeks. We use this drug actually quite a bit for neuropathic pain. So people who have chronic pain syndromes may benefit from tricyclics. Remember that in overdoses of tricyclics, ventricular arrhythmias can occur. So this is an important thing to keep away from people who have risk for suicide. All right. The example of this drug is Elavil. And then we talked about MAO inhibitors. Remember I said you eat a piece of cheese and you drop dead? Well, here's why. So Nardil, Parnate, Marplan, these drugs are the MAO inhibitors, and we really don't use them anymore at all. Because if you get any of these things, like aged wine, cheese, anything that's pickled, can cause all these symptoms: pounding heartbeat, tachycardia, hypertension, dizziness, tremor, sweating, and the hypertension can be severe and the arrhythmias can be life-threatening. And so these are drugs that we just don't use anymore. I mean, you can imagine being on an MAO inhibitor, going to a party and having fun with your friends, and oh, by the way, there's a piece of cheese that I forgot that I can't eat, and now I ate it and now I'm dying, right? It's a mess. So we don't use these drugs because we have other ones that are just about as effective. So anxiety, we talked about depression. Now we're going to talk about anxiety. Remember that there's different anxiety disorders. There's generalized anxiety disorder, panic disorder, and then PTSD is a form of anxiety disorder. And like depression, these things require treatment with drugs sometimes, and psychotherapy and relaxation techniques and exercise and all the other things that are that go along with a balanced regimen for getting patients better. The important thing to remember for SSRIs is that they are really good for anxiety. All right. When we start the SSRI, though, the anxiety may get worse. That's important to know. And so during that first 2 to 4 weeks, we typically give benzos as needed, PRN. And hopefully they, only need it for a week or two. Benzos, we've talked about. We're going to talk about them again. They're very commonly used. We don't recommend them for long-term use because they do have addiction associated with them. Withdrawal can also be a problem with those drugs too. They cause CNS depression. In elderly patients in particular, they put people at risk for falls. So we try and stay away from long-term benzos as much as possible. Bipolar disorder is also known as manic depression, right? So you've heard of patients who are manic depressives, and we now call that disorder bipolar disorder. But essentially, it's a cyclical condition where for weeks at a time, patients are depressed. And then as they cycle up, they go through the normal level of emotion and such and go right to a manic phase. And during that manic phase, they may not sleep well. I don't know if any of you were watching, so long ago, I think. You might not even remember it, but there was a show on Showtime, I think, called Homeland. And Carrie, who was the CIA agent in that, had bipolar disorder. And it was a pretty good description of her of bipolar disorder in her symptoms, where she was awake for long periods of time and not making really good sense and drawing conclusions that were really not based in reality. And they showed a picture of her apartment when she was working, night after night after night without sleeping. And she had these crazy graphs that were drawn and all these lines pointing, trying to tie things together. And she was coming up and she felt like she was putting together this major mystery that nobody else had ever put together before, because she had such clarity and she could see it for the first time. Those are some of the symptoms associated with manic episodes. And, the pressured speech and the racing thoughts and poor judgment and, grandiose thoughts. They're all very problematic. Now, I have had patients who have had bipolar disorder. I had one patient who was a research librarian when I was back in Philly, and she said, I love my manic phases because I get so much done. Like, I can get a ton of research done. Now, I don't know what the quality of the research was when she was in her manic phases, but, people certainly like that better than they like the phase of depression, for sure. But the whole idea of the drugs that we use for these conditions is to sort of settle it out so that they don't have the real big manic phases and they don't have the real deep depressions. And you kind of try and smooth it out so that patients are more at baseline all the time. Here's a little mnemonic that'll help you to figure out the difference between manic phases and depressive phases. I'll let you read that on your own. We use for bipolar disorder mood stabilizers like Depakote. Do you remember learning about Depakote? Yeah, it's an anti-seizure medicine. So Depakote and those other medicines like gabapentin and any of the other medicines that we use for seizures or for stabilizing the neurons, those medicines all have a role in bipolar disorder. But the classic one for bipolar disorder is lithium. And lithium is a drug that's old-fashioned. We discovered it a long time ago. We have no idea why it works, right? Exact mechanism of action unknown. But it has a narrow therapeutic index. A little bit doesn't do anything. A little bit more is just right. And a little bit more than that poisons your kidneys. So this is a medicine that you should just see a picture of a kidney when you think about lithium, because that's what is affected. All right. I want you to remember the kidney when you think about lithium, because that's the important thing. So we have to make sure that people who are on lithium have adequate hydration, and make sure that they don't become dehydrated, because that can increase the risk of toxicity. Okay. It's pregnancy category D. So actually, when Carrie got pregnant on Homeland, she had to stop her lithium, which had been working for a long time. And then they put her on some of these other medicines like Depakote. All right. And you're probably wondering why I'm using that example. I don't know, because I don't watch TV anymore. That was the latest example that I had of bipolar disorder. Common side effects with lithium are fine tremors, thirst. Remember it again, the kidneys and losing too much fluid and getting thirsty, polyuria, nausea, those kind of things. The serious adverse effects are coma, seizures, ventricular dysrhythmias, etc. All right. So these are not cuddly drugs. These are drugs that have to be monitored carefully. Here's some of the things that go along with and things for you to monitor with lithium toxicity. Ataxia, that is uncoordinated gait, right? Dizziness, slurred speech, confusion, coma, seizures, etc. The cardiovascular things are arrhythmias, often tied to kidney function and the electrolyte abnormalities that we've talked about. Hypotension can also result. Diarrhea, which makes all these things worse. Hypotension, arrhythmias, electrolyte abnormalities, etc. Okay? So we monitor people who are on lithium with serum drug levels, and we have to do that periodically, make sure that we're getting them the right dose. We also measure their BUN and creatinine, right? So the BUN, let's just ignore that. It's the creatinine. That's the thing I want you to know. The best assessment of renal function in a spot check is the creatinine. The best assessment of kidney function on a long-term basis in a stable patient, not in the ICU, for instance, is the glomerular filtration rate, or the GFR estimate. Okay. We also check the AST and ALT, which are the liver transaminases, make sure that it's not affecting the liver adversely, and the TSH, which is the thyroid stimulating hormone. Okay. Lithium nursing management. Effectiveness of therapy, right? We want to make sure that their symptoms are controlled. Make sure that they're not having any symptoms of toxicity, arrhythmias, hypotension, ataxia, those things that we talked about. Make sure that their fluid and electrolyte balance is on. Make sure that they adhere to the treatment plan. They avoid NSAIDs, because remember, NSAIDs poison the kidney, right? Not the liver. That's Tylenol that hits the liver. NSAIDs like Motrin hit the kidney and do things that are no good there. So that's about it. That's what I wanted to talk to you about today. I hope you have a good week. And next week we will have the first exam. Don't worry, you're going to do great. All right. Just study a little bit every day. Study with your friends or enemies. I don't care who, but think about how these drugs are used in clinical scenarios, what you as the nurse would be on the lookout for if you had somebody who was on lithium and Motrin, for instance. Talk about those things, discuss them out loud. And I think that will help you to prepare for the exam better than coming up with like flashcards, right? Because it's not about memorizing the 19 symptoms that go along with lithium toxicity. It's about knowing how to apply those things in a clinical scenario. I'm around in my office all week. Actually, that's not true. I'm around in my office Wednesday afternoon or Friday afternoon. I can be available to you Tuesday, and I'm available in the evenings any day this week. If you want to have a Zoom meeting, a little video conference with me in the evenings, that's fine. Just let me know if you need any help, and I'm here to help you succeed. All right.